Silva Oration for the year 2023. To commence tonight's proceedings, we will now have the entrance of the ceremonial procession. Please rise. Please remain standing for the national anthem.
Sri Lanka Mata, Abba Sri Lanka, Namo
On behalf of the College of Community Physicians of Sri Lanka, I would like to invite the following distinguished guests and members of the college to light the traditional oil lamp. The President of the College of Community Physicians, Dr. S.M. Arnold, our orator for tonight, Dr. Damit Gunawardana, Dr. Stanley De Silva, representing the past presidents of the college, to represent fellows, Dr. Ayesha Lukubala Surya, representative of the family of the orator, Mr. Ravi De Silva, official from the Ministry of Health, Dr. Chitramali De Silva, Dr. Vinya Aryaratna, President of the Sri Lanka Medical Association, Professor S.D. Dharmaratna, Chair Professor of Community Medicine, University of Peradeniya, Dr. Dhammika Rowell, Dr. Prabhat Ranasinghe, Consultant Community Physician, Provincial Directorate of Health Services, Central Province, Orator's family member, Dr. Namal Ulluis Heva, Secretary of the College of Community Physicians, Dr. Tushani Dabarera, Treasurer of the College of Community Physicians, Dr. Atula Liyenapathirana. Thank you, ladies and gentlemen. Please be seated. To preside at the head table, I would like to call upon the following dignitaries. President of the College of Community Physicians of Sri Lanka, Dr. S.M. Arnold, our orator, Dr. Damit Asanga Gunawardana, Dr. Tushani Dabarera, Secretary of the College of Community Physicians, and the Treasurer of the College of Community Physicians, Dr. Atula Liyenapathirana. Thank you. I would now like to invite the President of the College of Community Physicians, Dr. S.M. Arnold, to deliver the welcome address.
Good evening, past presidents, fellows, members of the council, members of the College of Community Physicians of Sri Lanka, members of the family of Dr. A.V.K.V. De Silva, our orator, Dr. Dhammika Asanga Gunawardana and family, and distinguished invitees, ladies and gentlemen. Thank you everyone for being with us today. We are very pleased to welcome all of you to this very important annual event of the college. Now I would like to read a citation of Dr. A.V.K.V.D. Silva. Dr. A.V.K.V.D. Silva, one of the most significant epidemiologists of our country, whom we commemorate today through an epidemiology-related oration, was born in 1930. He received his MBBS in 1955 and completed Diploma in Public Health from University of Edinburgh in 1965, where he was placed first in the exam and awarded Public Health Medal. He then completed Diploma in Epidemiology from University of Prague and Delhi in 1970 and also completed the certificate course in nutrition from University of Hyderabad, India in 1968. He completed his MD in community medicine from University of Colombo in 1980 and was made a board certified consultant in community medicine in 1980. He was made a fellow of the College of Community Physicians of Sri Lanka in 1996. Throughout his illustrious career in epidemiology and public health, he dedicated his life to uplift public health through epidemiological approach to health and in various capacities. Dr. A.V.K.V.D. Silva started his career in public health as a medical officer of Health Panadura and rose in his ranks to the position of Regional Epidemiologist Kalutara and Assistant Epidemiologist Ministry of Health. In 1975, he was appointed as the Deputy Epidemiologist to the Ministry of Health, and in 1982-1986, he headed the Epidemiology Unit as the Chief Epidemiologist to the Ministry of Health. As a public health specialist, Dr. A.V.K.V.D. Silva displayed an enormous capacity engaging in advocacy, program management, and financial management. He was the program manager for hallmark public health programs such as the expanded program of immunization, diarrheal diseases control program, and annual malaria review, and was a national consultant for the World Health Organization and UNICEF. His international career in public health started in 1986 when he was appointed as the epidemiologist control of diarrheal diseases program in WHO Southeast Asian Regional Office in New Delhi. He functioned as a team leader, inter-country supervisor, program reviewer, and a researcher for policy in his capacity. He was also engaged in numerous other consultancies to the World Health Organization, UNICEF in the region regarding control of cholera epidemic, EPI, and public health reviews. Dr. A.V.K.V.D. Silva carried out a large body of important and policy-altering research and has numerous national and international publications to his credit in the areas of diarrheal disease, cholera, neonatal tetanus, EPI program, healthcare systems, and oral rehydration therapy. He was awarded the Joint Presidential Award in 2001 for his paper on healthcare systems in transition, current status of HIV in Sri Lanka. Throughout his dedicated and exemplary life in public health, Dr. A.V.K.V.D. Silva platformed the strength of epidemiology and science in transforming the health of communities and countries. He was an emissary of strength of epidemiological approach to health in the region. He displayed a wealth of knowledge and put epidemiology and the use of it to solve public health questions in the health limelight. The College of Community Physicians of Sri Lanka bows its head today to this legend through conducting the annual Dr. A.V.K.V.D. Silva Memorial Oration. I thank you.
Thank you, sir. Ladies and gentlemen, we have now reached the highlight of the evening. I would like to cordially invite Dr. S.M. Arnold once again to read the citation of our orator, Dr. Damitha Asanga Gunawardana.
Dr. Damitha Asanga Gunawardana is a board-certified specialist in community medicine and a senior lecturer in community medicine, Faculty of Medicine, University of Peradeniya. He received his primary and secondary education from Dharmaraja College, Kandy, during which he had an illustrious career as a student. Dr. Gunawardana graduated from the Faculty of Medicine, University of Peradeniya in 2007. Immediately following his internship, Dr. Gunawardana started his public health journey as an additional MOH in MOH Kantale in 2009. He started his postgraduate studies in public health in 2011 and obtained the Masters in Community Medicine from the University of Colombo in 2012. Dr. Gunawardana obtained Doctor of Medicine in Community Medicine degree from the Postgraduate Institute of Medicine, Colombo in 2015. Following his local SR training in Family Health Bureau, he was attached to the Health Economics and Policy Unit of the School of Public Health, University of Adelaide, as a postdoctoral research fellow in 2017. He has been a board-certified specialist in community medicine since 2017 and is a fellow of the Royal Society for Public Health, United Kingdom. During his public health career, he has served as a medical officer of maternal and child health in Kegol and Kandy district and as a consultant community physician in RDHS Kandy, Kegol, Nuwara and PDHS Central Province. Following 12 years of service in the Ministry of Health, he joined the Department of Community Medicine, Faculty of Medicine of Peradeniya University as a senior lecturer in 2021 to pursue an academic career because of his passion for teaching. Dr. Gunawardana has published numerous research papers in national and international journals. His main research interests are health economics, disease burden, and maternal and child health. He has also been a reviewer for several national and international journals, including the Bulletin of the World Health Organization. Dr. Gunawardana won first place in oral presentations on maternal and child health and nutrition at the 21st Annual Academic Sessions of the College of Community Physicians of Sri Lanka, held in 2016. Dr. Gunawardana has been selected by the Intra-Academy Medical Panel and the World Academy for Sciences as one of the 20 outstanding young physician leaders in the world to participate in the Young Physician Leaders Forum in conjunction with the World Health Summit in 2018 in Berlin, Germany. Since then, he has been invited as a resource person for joint workshops organized by the Inter-Academic Partners and UK Academy of Medical Sciences, including the workshop on universal health coverage and in low and middle income countries held in London in 2019. Further, Dr. Gunawardana has contributed to developing national level standards, guidelines and policies, including cost analysis reports on every newborn action plan and strategic plan for adolescent and youth health in Sri Lanka. He recently performed a consultant contract with the WHO to revise the supervision framework for reproductive, maternal, newborn, adolescent and child health program in Sri Lanka. Dr. Damitha Asanga Gunawardana was born to late Mr. W.G.D. Gunawardana and A. Anoma Rodrigo. Dr. Gunawardana is married to Mrs. Shanika Walakura Arachi, and they are blessed with a little daughter, Ishini. It is great pleasure to award the medal of Dr. A.V.K.V. De Silva Oration to Dr. Damitha Asanga Gunawardana, and I invite him to deliver the oration today.
The President will now award the College of Community Physicians Orators Medal to Dr. Damitha Asanga Gunawardana. Thank you, sir.
Thank you very much, sir, for that kind introduction. Very good evening to all of you, the President, past Presidents, Fellows, members of the Council of the College of Community Physicians of Sri Lanka, family members of late Dr. A.V.K.V. De Silva, dear teachers, friends, ladies and gentlemen. It is a great privilege for me to deliver this oration today in memory of late Dr. A.V.K.V. De Silva, a pioneer public health specialist in Sri Lanka and one of the most significant epidemiologists in our country. Dr. A.V.K.V. De Silva headed the epidemiology unit as the chief epidemiologist of the Ministry of Health from 1980 to 1986. He was the program manager for hallmark public health program such as the expanded program of immunization, diarrheal disease control program, and annual malaria review. He was the national consultant for the WHO and UNICEF. His dedicated work has significantly contributed to the current improvement of the public health indicators of the country. He and his generation of health professionals untiringly fought for the well-being of his fellow countrymen and women. As new generation of public health professionals, the challenges ahead of us are rather different and complex. President and distinguished invitees, today I will talk about neonatal outcomes, maternal risk factors, and the cost of management of adverse neonatal outcomes among term neonates. The topic I have selected is, are term neonates too small to be seen? Sri Lankan scenario. This presentation is based on a research project started at a time these aspects were not previously assessed in Sri Lanka. Every day, 6,500 babies die in first month of life. Every year, an estimated 2.6 million newborns die worldwide. In current trend, if current trend continues, 48 million children under the age of 5 years are projected to be die between 2020 and 2030. Half of them newborns. Therefore, further reduction in child mortality will only be possible through improving newborn health. A neonate born at term is a neonate born at term gestation. Conventionally, the term gestation is defined as period of gestation from 37 completed weeks up to and including 41 completed weeks and 6 days. Identification of newborn at term depends on determining the gestation period. Nearly half of all under 5 deaths in 2020 occurred during neonatal period. This increases from 1990 as global level of under 5 mortality declines faster than neonatal mortality. 5 million children died before their 5th birthday and half of them were newborns. Mortality can be assumed to be just the tip of the iceberg in a disease that kills, but often will road to survivors into long-term effects. Underestimating and neglecting neonatal diseases carries this burden into adulthood, resulting in economic and social costs. After recognizing the importance of this issue, WHO and United Nations International Children's Emergency Fund proposed every newborn target for the post-MDG era to meet every newborn target of 10 or fewer neonatal deaths and 10 or fewer stillbirths per 1,000 births in every country by 2035. Neonatal disorders are considered to be the leading cause of disability-adjusted life years in whole age groups globally. When considering under 10 age group, in 2019, neonatal disorders accounted for 32.4% of the group's global deaths, increasing from 23% in 1990. Globally, 80% of neonatal deaths are due to three leading causes: prematurity and low birth weight, perinatal complications and asphyxia, sepsis, and infections with regional variations. A large prospective cohort based on vulnerable verbal autopsies in 8 countries in sub-Saharan Africa and South Asia found birth asphyxia and sepsis accounted for 70% of neonatal deaths, and preterm birth complications might be the third cause of neonatal mortality. With these discrepancies, detailed causal information on neonatal deaths are urgent need to identify true causation, to identify the real bottlenecks to achieve SDG targets. Sri Lanka is a country that has successfully reduced the neonatal mortality rate over the years and is on track to achieve the SDG targets by 2035. Sri Lanka has reduced the infant mortality rate from 17.9 in 1992 to 8.5 in 2015, and neonatal mortality rate was 13 in 1992 and 6 in 2015. However, neonatal deaths account for more than 80% of infant deaths. Therefore, further reduction in infant mortality will only be possible through improving newborn health. Major causes of neonatal mortality in Sri Lanka are prematurity, congenital anomalies, birth asphyxia, neonatal sepsis, and meconium aspiration syndrome. Globally, the ability to evaluate trends and risk factors across spectrum of term gestation is limited for mortality and hardly available for morbidity. Therefore, it is important to study the neonatal outcomes, including both favorable and adverse outcomes and their associated factors, to identify the areas of maternal and neonatal care that will need specific focus to prevent adverse outcomes among term neonates. Recent data indicate that the neonatal morbidity rates were not the same across 5 weeks gestational age range that constitute term. And there is a research evidence to show the frequency of adverse neonatal outcomes among term neonates in U-shaped distribution within term gestation. Even though few studies on term neonates were available for discussing neonatal care services, the proportion of term neonates who required admission to neonatal special care units due to adverse outcomes may vary from 10 to 15%, while term neonates may make up even 40 to 70% of neonatal intensive care unit population. Following a detailed analysis, John and others concluded that even though the cost of surviving an extreme premature baby is high, the cost for extreme premature infants is a small component of the total neonatal cost, because only a relatively few babies are born preterm compared to term gestation. Studies undertaken to determine the cost of initial hospital care for newborn infants according to gestational age at birth and survival status found that total cost of initial care for US population of neonates is $10.2 billion annually, and out of that, 42.7% were spent on those born at more than 37 weeks of gestation. Although cost evaluations of newborn care are increasingly available for other countries, costing data on Sri Lankan neonatal care services are largely unavailable. Studies by Nelumdeni and others, and Loganathan and others also focused on extremely low birth weight and premature neonates, respectively. Almost 85 to 90% of babies are born at term in Sri Lanka. Even though the risk of adverse neonatal outcomes of birth at term is less compared to preterm and post-term births, term neonates are responsible for significant proportion of newborns requiring intensive and special newborn care. Therefore, the pattern of outcomes and the knowledge of the risk factors associated with those outcomes are essential in guiding preventive strategies and clinical decision making. Some risk factors might not be preventable, but identifying adverse neonatal outcomes and neonatal intensive care admission risk may help focus on interventions for further improvements in newborn health. Further, early identification of risk conditions might maximize the impact of the intervention. In addition, it is important to identify the burden of term neonates on neonatal intensive care units and special baby care units to make rational policy decisions in the management of neonatal care services in the country. With the current economic crisis, utilizing limited resources available needed to be done wisely. Even though term neonates may make up 40 to 70% of the neonatal intensive care unit population, no previously published costing studies were done among term neonates who required admission to the special neonatal or intensive care. Available studies mainly focused on highly premature or premature neonates admitted to the neonatal care units. To bridge this gap, local evidence on term neonates, outcomes of the term neonates, maternal risk factors for them, and cost for adverse neonatal outcomes, which will signify the importance of preventing and managing adverse neonatal outcomes among term neonates, were studied as described below. Neonatal outcomes of term deliveries before the initial hospital discharge in Sri Lanka. The neonatal outcomes of term neonates following term deliveries at a teaching hospital in Sri Lanka were assessed by Gunawardena and others. A descriptive follow-up study was conducted to describe neonatal outcomes of term neonates before the initial hospital discharge point. A sample of 1,105 neonates delivered at term was studied during the study period. Following term neonates were excluded from the study: neonates of the mothers with uncertain last menstrual period, neonates of mothers who did not have an ultrasound scan before completion of 24 weeks of gestation, neonates of the mothers whose ultrasound scan expected date of delivery is different from EDD calculated from the LMP more than 14 days, and neonates who were transferred out from the hospital. The study's first three exclusion criteria were used to minimize the chance of preterm or post-term neonates getting into the study group. The mean gestational age at delivery was 38.8 weeks. Most of the term neonates were delivered at 40 weeks. Out of all, 41% were delivered before the completion of 39 weeks. Pereira and others also reported similar finding in their study, where 42% of term neonates were delivered before completion of 39 weeks. The mean birth weight of term neonates in the present study was 2,925, while 13.7% had birth weight less than 2,500 grams, and 10.9% had a birth weight of either 3,500 or more. Mean birth weight was consistent with the findings of study done by Pereira and others, where they reported the mean birth weight of neonates as 2,930 grams. Length of hospital stay was measured in inpatient days. National policy on hospital discharge of a term neonate with normal birth weight is to discharge after 24 hours of birth following normal vaginal delivery. 68% of neonates who delivered through normal vaginal delivery were discharged within 2 days. The median hospital stay was 3 days, mainly due to a higher cesarean section rate among the study group. Of 1,105 neonates included in the study, 23.3% had at least one diagnosed neonatal condition. Out of all term neonates in the study, 15.8% of neonates required neonatal care unit admission. Most term neonates admitted to neonatal care units were admitted during first day of life. The commonest neonatal condition was bacterial sepsis of newborn, followed by neonatal jaundice from other causes and unspecified causes, and respiratory distress of newborn. High levels of bacterial sepsis need to be addressed by improving the aseptic practices from the time of birth to time of discharge from the hospital. Of the term neonates included in the study, only one term neonate died due to meconium aspiration. Therefore, the mortality was very low among the study group. This was consistent with the finding of the study done by Amir and others, where they reported mortality rate of 0.69 per thousand live births in a similar study group. Neonatal outcomes and neonatal care received by term neonates following initial hospital discharge in Sri Lanka. Follow-up study of 1,105 neonates included in the study by Gunawardene and others was conducted to capture the neonatal outcomes following initial hospital discharge. A telephone interview was planned among term neonates of mothers who consented to participate in a such interview from 29th and to the 35th day following delivery for the neonates who had been already discharged from the hospital. From the 770 mothers who were initially recruited before discharge from the hospital, only 57.4% of the mothers could be contacted. But 21 mothers refused to participate in the study, hence only 421 mothers participated in the study and completed the telephone interview. Nearly half of the mothers sought medical advice for their neonates following hospital discharge. Out of mothers sought medical advice, 71% went to ordinary doctors, while 28% consulted specialist doctors. All the mothers who mentioned having some kind of a neonatal health problem sought medical advice from the health professional. This is very important practice to maintain a relatively low neonatal mortality rate in Sri Lanka. Exclusive breastfeeding is given no other food or drink, not even water, except breast milk. It does, however, allow the infant to receive oral rehydration salt, drops, and syrups. Most women exclusively breastfed their babies. Breastfeeding status refers to a past 24 hours period. Out of 6 formula-fed babies, 1 had hospital admission, while 4 out of other 5 babies had sought medical advice from either a specialist or an ordinary doctor. The exclusive breastfeeding rates was higher than the Demographic Health Survey 2016 and 17 report, where the exclusive breastfeeding rates was 93.4% and 1.8% of formula feeding at 1 month of age. This difference could be due to the difference in the gestational age at birth, since premature neonates are generally at higher risk of initiation of formula feeding. Importantly, 5 neonates who had been on formula milk had received medical attention from a qualified medical practitioner. So it is important to convince all medical practitioners with regard to the importance of exclusive breastfeeding over formula feeding. There were no deaths among studied neonates following initial hospital discharge until their neonatal period was over. 19 neonates were hospitalized during the neonatal period, and most common reason for admissions was breathing difficulty followed by yellow coloration of the body. The policy is that PHM should make the first postnatal visit within 1 to 5 days of delivery, and in this sample, only 37% had received first visit in stipulated period. 78% had received first home visit from PHM within first 10 days of delivery. Only 3% of neonates did not receive any postnatal visit by PHM by the time of the telephone interview. Majority of neonates had received an appointment for the postnatal clinic visit by the time of the survey. 6 key aspects of postnatal care at home supported by PHM were assessed based on the mother's responses at the telephone interview. A considerable proportion of mothers stated that postnatal visits were not helpful in any of the 6 aspects questioned in the telephone interview. Postpartum visits had the highest impact on breastfeeding, followed by maternal competence in recognizing danger signs. But postpartum visits had the least impact on keeping the baby warm and dressing up of the baby. Maternal risk factors for adverse neonatal outcome following term deliveries in Sri Lanka. Gunawardena and others conducted a secondary data analysis on a database of descriptive follow-up study on term neonates to identify the maternal risk factors for adverse neonatal outcome following term deliveries. Analysis was performed as an unmatched case control study. Cases were defined as term neonates with adverse neonatal outcome, a composite measure of neonatal death and morbidity that needed admission to neonatal care unit before the initial hospital discharge point. Controls were defined as term neonates who were alive and did not require admission to neonatal care unit until the initial discharge point. With low prevalence of outcome, a 1:3 ratio between cases and controls was taken to increase the power of the study. Based on the calculated sample size, 170 cases and 525 controls were studied. Multivariate analysis showed the maternal educational level of degree or above as a protective factor for adverse neonatal outcomes among term neonates. This could be due to the relationship between educational level and health literacy. When considering the mother's occupational status, professionals had a higher risk of adverse neonatal outcomes at term in the multivariate analysis. The low threshold for admitting term neonates of professionals, including healthcare professionals, could be the reason behind this. More than half of the mothers of neonates with adverse neonatal outcomes were primiparous mothers. The risk of adverse neonatal outcomes in primiparous mothers was 1.5 times more than that of multiparity mothers. This may be due to the low awareness of antenatal and postnatal care among primiparity mothers than the multiparity mothers. Out of 119 mothers with at least one antenatal complication during the present pregnancy, 44% had PIH, followed by GDM, vaginal bleeding during the antenatal period, and intrauterine growth restrictions. Of those, PIH and GDM were associated with adverse neonatal outcomes among term neonates. Early diagnosis and treatment of both these conditions should be ensured by strengthening the implementation of guidelines given in the National Maternal Package in Sri Lanka. When considering the POA at birth, delivery at 47 weeks was significantly associated with adverse neonatal outcomes among term neonates. This finding accords with a population-based study done in Australia, which reported, irrespective of the mode of delivery, deliveries that occurred at 37 weeks had the highest risk of neonatal intensive care unit admissions at term, followed by 41 and 38 weeks. Furthermore, Sutton and others reported a significant association between deliveries occurring at 37 and 38 weeks and neonatal intensive care unit admissions among term neonates. Gunawardena and others found 23.5% of labor inductions and 66.7% elective sections were done at 37 or 38 weeks of gestation. All these findings signifies the importance of preventing any non-medically indicated elective inductions or cesarean sections at 37 weeks of POA. In the present study, induction of labor was a significant risk factor for the adverse neonatal outcomes among term neonates in the bivariate analysis. This finding was accords with those those of study by Sutton and others. When considering the mode of delivery, a caesarean section with labor was found to be associated with adverse neonatal outcome at term compared to normal vaginal delivery. A similar finding has been reported by Tracy and others, where the higher risk of neonatal intensive care admissions of term neonates was noted among caesarean sections with labor at 40 weeks of POA. This signifies the importance of delaying and elective inductions until 41 weeks of POA, since the caesarean section following failed inductions will considerably increase the risk of adverse neonatal outcomes at term. Neonatal care cost of adverse neonatal outcomes following term deliveries in Sri Lanka. Gunawardene and others conducted a cost analysis to explore the neonatal care cost of term neonates with adverse neonatal outcome. 175 term neonates with adverse neonatal outcomes followed up in the study. The main perspective taken was that of Ministry of Health Sri Lanka. Even though the analytical costing study would be a better option, this study was conducted just as a cost analysis due to the limitation of available hospital-level data. Further, disease costing studies concerning neonatal care have not been conducted in Sri Lanka previously. So, this would be the first one of that kind. Total neonatal care cost during the study period, including government and out-of-pocket cost, was 12.1 million rupees, of which 92.9 consisted of government neonatal care cost. The largest contribution to the government neonatal care cost of term neonates with adverse neonatal outcomes was by shared direct cost, including staff salaries and allowances, cost of surgical consumers, cost of shared equipments. 90% of shared direct cost consisted of staff salaries and allowances. In the present study, the cost of drugs was higher than that of laboratory tests. With the relative high prevalence of neonatal sepsis, the main contributor to that was the antibiotic treatment. The median total neonatal care cost per term neonate with adverse neonatal outcomes was 50,000 rupees with an interquartile range of 30,000 to 79,000 rupees. Neonates admitted to neonatal care unit on the first day of life had higher average neonatal care cost than those admitted later. Deliveries at 37 weeks, male sex, birth weight less than 2,500 grams was associated with higher mean total neonatal care cost per term neonates with adverse neonatal outcomes. For most prevalent neonatal conditions among term neonates with adverse neonatal outcomes contributed to 69.5% of total cost. Respiratory distress syndrome is responsible for the most significant proportion of the total neonatal care cost. This high cost among term neonates with respiratory distress syndrome was due to the higher proportion of cases and costly ventilator support, which is associated with using several other expensive therapeutic modalities such as continuous positive pressure, airway pressure, therapy machine, and blood gas analyzer. But when considering the neonatal care cost per term neonate, birth asphyxia was the most costly neonatal condition to be managed. If assumed 15% of term neonates need neonatal care unit admissions and 85% of all live births are term deliveries, all live births are term deliveries, nearly 41,300 term neonates need to be admitted to neonatal care unit per year in Sri Lanka. Then based on the median total neonatal care cost per term neonates with adverse neonatal outcome of 369 USD reported in the study by Gunawardene and others, it will cost 12.9 million USD per year. A 5% reduction in adverse neonatal outcome among term neonates, thereby reducing the neonatal care unit services requirement, will save 4.3 million USD annually. This amount will be enough to develop 10 level 3 neonatal care units as per the Every Newborn Action Plan of Sri Lanka, costed by Gunawardena and others. There are quite direct implications of the evidence generated to promote the health of term neonates in Sri Lanka. Induction of labor is recommended for low-risk women who are known with certainty to have reached 41 weeks of gestation, since caesarean section with labor is identified as a very strong risk factor for adverse neonatal outcomes among term neonates. Implementing national guidelines on maternal care that includes the guidelines on labor induction is strongly recommended. Any other non-medically indicated elective deliveries at 37 weeks should be avoided, since it is a strong risk factor for adverse neonatal outcome among term neonates. Prevention and control of infection at the time of birth in the labor room and the operation theatre, in the postnatal wards and in the neonatal units should be given due attention to reduce the bacterial sepsis among term neonates. The use of clinical audit checklist for labor management and labor induction, caesarean sections, and prevention of control of infection at birth in the postnatal wards and neonatal care units will improve newborn health. A clinical auditing system and a review mechanism should be developed to routinely monitor the indications and outcomes regarding induction of labor, the inductions for caesarean sections, and rate of infections in the postnatal wards and neonatal care units. In-service training for the staff caring for mothers and newborns in the management of labor and care of newborns should be available regularly to ensure the maintenance of skills and the competencies. The effective coverage of postnatal domiciliary care needs to be improved. Methods to ensure timely postnatal visits by PHMs need to be evolved. The skills and competencies of the PHMs in provision of domiciliary care for neonates should be improved. Especially to guide the mother in essential care of newborn should be improved using techniques such as observation checklist. More research is also needed to understand the most appropriate approaches in the field neonatal care to maximize the impact of postnatal visits by public health midwives. Considering the cost implications, the adverse outcomes among term neonates, all possible measures must be taken to prevent them, especially as a country thriving through an economic crisis. Thank you. At this juncture, I sincerely thank my beloved supervisor, Professor Samath Dharmaratna and Dr. Dhammika Rowell for their continuous guidance. At the same time, the Director Family Health Bureau and all the program managers in past and present for their support. President, Secretary and Council members of CCPSL and the family of Dr. A.V.K.V.D. Silva. Thank you very much for this opportunity to share this evidence on newborn health among term neonates. Dean, Faculty of Medicine, Peradeniya, and all my department colleagues are remembered at this moment, thankfully, for their kind support. A special thank go to Dr. Yasasri Walpita, Professor Nuwan Wickramasinghe, and Dr. P.T.S. Prasanga, who helped immensely in delivering this oration. Last but not least, I thank my parents, my sister, my wife for being my strength in every step of the way. And my little daughter, the actual term neonate behind all these, who kept me on the bench outside the neonatal care unit for the first 10 days of her life. Thank you.
Thank you very much, Dr. Damita Sangagunawardana, for that intriguing and enlightening oration and educating us on our term neonates too small to be seen, Sri Lankan scenario. We have now reached the end of the evening. To propose the vote of thanks, I cordially invite Dr. Tushani Dabarera, Secretary of the College of Community Physicians.
Thank you, Dr. Dakshila, for the kind introduction. Good evening. President, the orator tonight, Dr. Damita Gunawardana, and the Council of the College of Community Physicians of Sri Lanka, past presidents, and all the fellows of the College of Community Physicians of Sri Lanka, family members of AVKV De Silva, all the officials of the Ministry of Health, academia, representatives from the WHO, UNICEF, and other donor agencies, distinguished guests, ladies and gentlemen. It is my honor and privilege to have been given the opportunity to present a vote of thanks as the Secretary of the College of Community Physicians of Sri Lanka on this momentous occasion. I must also take a moment to extend my appreciation to our distinguished orator, Dr. Damita Gunawardana. Your insightful and thought-provoking oration on neonatal health has enriched our understanding of this crucial area of medical practice. I would like to extend my heartfelt gratitude to the family of Dr. A.V.K.V. De Silva. Your unwavering support and encouragement have been instrumental in honoring the memory of your beloved family member. Dr. A.V.K.V. De Silva's legacy lives on through this oration, and we are grateful for the opportunity to commemorate his exceptional contributions to the field of community medicine. President, past presidents, fellows, council members, and all the members of the College of Community Physicians of Sri Lanka. Thank you very much for extending your immense support to make this event a success. On behalf of the college, I extend our gratitude to all the Ministry of Health officials, academia, and UN agencies for being with us today to grace this occasion. Thank you, Chair and members of the Oration Subcommittee of the College of Community Physicians. Your hard work and commitment in arranging this event beautifully is very much appreciated. A special word of appreciation to all the postgraduate trainees for taking the burden onto your shoulders in arranging this event. President, Sri Lanka Medical Association and the staff, thank you very much for your assistance in making this event a reality. And our college assistant, Mr. Tushara. Thank you, Mr. Tushara, for your continuous support. Dr. Dakshila Galappatti, thank you very much for the eloquent comforting tonight. And last but not least, all the invitees who joined with us physically and virtually, thank you for being with us in spite of your busy schedules and the long weekend. We invite all of you for the refreshment. Thank you very much.
Thank you, Madam. Ladies and gentlemen, that brings us to the conclusion of the proceedings tonight. The Council of the College cordially invites you all for refreshments outside. Please rise. The ceremonial procession will leave the hall. Thank you and wishing all of you here a very good night.